Hi, my name is John Tsai, and in this video we will be discussing acid-base regulation and how we can interpret the blood gases of patients to help determine what is happening to them and how to correct the underlying issue. We will delve into how the pulmonary and the renal systems work hand in hand to ensure that the pH of our body remains constant. Recall that our pulmonary system is responsible for excretion of volatile acids, or acids that can be converted into gas, primarily carbon dioxide. This is usually in the form of carbonic acid that is converted into carbon dioxide and water in the lungs, and then we're able to excrete the carbon dioxide in our alveoli and subsequently breathe it out to help continue driving secretion of these volatile acids. Unfortunately, while the lungs are very efficient at getting rid of carbon dioxide and volatile acids, they are not able to get rid of non-volatile acids, and that is dependent upon good kidney function. Our renal system is slow, but as you remember from your previous discussion on renal acid handling, it is an important part of acid homeostasis. There is one equation that helps us understand how pH, carbon dioxide, and bicarbonate levels interplay in our body, and this is the Henderson-Hasselbalch equation that you may have seen in your biochemistry courses in college. We can use this equation to estimate changes to each of the other components when we adjust some of the parameters. The PCO2, or partial pressure of carbon dioxide, is mainly a respiratory-driven number determined by ventilation. The more breaths we take per minute, the higher the ventilation and the ability to get rid of carbon dioxide, so our partial pressure of carbon dioxide will go down. Conversely, if you were to hold your breath for a minute, then the carbon dioxide would start to accumulate and your PCO2 levels will increase. The bicarbonate level, on the other hand, is mainly a renal-driven number. The kidneys are the major source of non-volatile acid excretion, so if we were to maintain these acids in our body, or if we had some issue with the bicarbonate production or reabsorption, then we will start to decrease our serum bicarbonate levels. Alternatively, if we somehow add too much alkali to our body or get rid of too much acid, then the bicarbonate levels will go up. With the Henderson-Hasselbalch equation, we can see that if we were to increase our bicarbonate in our body, then our pH will increase. Conversely, a decrease in the bicarbonate concentration will result in our serum pH decreasing, or the state known as acidemia. Acidemia is the state of a low pH, whereas acidosis is a process that results in acidemia. We can also see similar changes when we cause changes to our PCO2. If we increase our respiratory rate and blow off a lot of CO2, then our partial pressure of carbon dioxide will decrease, leading to an increase in pH since PCO2 is in the denominator of the equation. Conversely, carbon dioxide retention increases the partial pressure of carbon dioxide, leading to a lower pH and acidemia. Let's explore the respiratory component of the Henderson-Hasselbalch equation further. Let's take again the example where we decrease our ventilation. This increases carbon dioxide retention, which will increase the partial pressure of carbon dioxide seen in step 1. This will then result in a decrease in pH in step 2 because the primary issue here is that the decrease in the pH is a pulmonary issue. We call this a respiratory acidosis. If we increase our ventilation, the opposite occurs and our partial pressure of carbon dioxide will decrease, leading to a lower pH and what we call respiratory alkalosis. Let's explore the metabolic component of the Henderson-Hasselbalch equation now. If we increase acid generation or decrease acid generation, then this will cause our bicarbonate buffer stores to decrease. The usage of bicarbonate then will lead to a decrease in pH, leading to acidemia. Since the bicarbonate was the primary cause of the low pH, this is called a metabolic acidosis. Conversely, if the bicarbonate is increased, for example, due to an increase in bicarbonate production, then the pH will increase in the process known as metabolic alkalosis. So you can see that we can use a pH, PCO2, and bicarbonate levels of a patient to help us determine the acid-base disturbance going on in the patient and to quickly identify what is problematic and correct the issue before it's too late. There are several reasons why pH will be abnormal, and identifying a metabolic versus a pulmonary process will be the first step at knowing what we need to do next. How does this work in clinical practice? Well, we usually look at the pH first, then we backtrack from what we have learned over the last couple of slides to help us determine if it's a metabolic or a respiratory process primarily occurring. If we have a low pH or an acidosis, and if it's coupled with a low bicarbonate level, then we can generally assume that the primary issue is a metabolic process and diagnose the patient with a metabolic acidosis. Conversely, if the PCO2 is elevated in the setting of a low pH, then we know that this is consistent with a respiratory process, and hence we diagnose the patient with a respiratory acidosis. Similarly, if the pH is high and we have alkalosis, we look at the direction of the bicarbonate and the PCO2 to determine if it's a metabolic or a respiratory process. I would encourage you to pause the video here to ensure that this slide makes sense before continuing, since this is the first and most basic step to analyzing blood gases. Let's now talk about compensatory mechanisms, first by starting with the renal compensatory mechanisms for respiratory processes. Remember that pulmonary processes are fast. They take on the order of minutes to hours to occur, whereas renal processes take hours to days to occur. This means that affecting our PCO2 is much easier compared to affecting our bicarbonate levels, since the respiratory system is a much more efficient way to get rid of excess acid through the production of carbon dioxide, assuming that it is a volatile acid and not a non-volatile acid. In the coming slides, we are going to see what happens in the kidneys when we have a primary respiratory acidosis or alkalosis. In a primary respiratory acidosis, our PCO2 rises, let's say for example from 40 to 60. From the Henderson-Hasselbalch equation, we know that this will ultimately lead to a decrease in pH consistent with a primary respiratory acidosis. The low pH stimulates reabsorption and generation of bicarbonate in the kidney, as well as elimination of more acid. But since this takes time, the bicarbonate levels usually take hours to days to slowly rise, helping to bring the pH back to more normal levels. We have formulas that we can use to calculate the expected increase in the bicarbonate levels, as shown here on the right. For each 10 millimeters of mercury increase in PCO2, we expect the bicarbonate level to increase by about 1 to 4, depending upon if the process is acute or chronic. Remember, since the kidneys are slow at compensating, it will take time for the bicarbonate levels to increase significantly, and that is what differentiates an acute versus a chronic process. Let's take, for example, that the PCO2 has increased from 40 to 60 now. Since this represents a 20 increase from normal in the acute setting, we expect the bicarbonate to increase from 24 by 2 to about 26. In the chronic setting, we would expect the bicarb to increase from 24 by 8 to about 32. If we track what's going on here in the Henderson-Hasselbalch equation, we can calculate that the increase in PCO2 from 40 to 60 will result in a decrease in pH from about 7.4 to 7.22 if our bicarbonate levels stay the same. Now in step 3, our renal compensation will try to increase the pH back to 7.4 by increasing bicarbonate, and we can calculate that the bicarbonate level will increase from 24 to 36. Now, our body doesn't necessarily do this since there are several factors at play. So the equations that we are presenting here only illustrate the underlying concept and not necessarily the physiological response to what actually happens in the body. In reality, the bicarbonate level will increase, but not by that much, since it's not necessary to completely bring the pH back to normal levels of 7.4. In addition, we usually increase our ventilation rate to compensate for the higher respiratory acidosis in an attempt to blow off more carbon dioxide and bring the pH back to normal. Given all of these physiological responses, we expect a correction of about 1 to 4 in our bicarbonate for every 10-point increase in our PCO2, and that is reflected in the formulas that we use to calculate the expected renal response to respiratory acidosis, as was shown in the previous slide. Now, let's take a look at the opposite direction where we have a primary respiratory alkalosis. A primary respiratory alkalosis is relatively rare and chronically only found in few physiological conditions outside of a ventilated patient. Hyperventilation or any medications that induce hyperventilation can cause a respiratory alkalosis. Additionally, liver disease and pregnancy round out the most common causes of chronic respiratory alkalosis. Recall that in a respiratory alkalosis, the PCO2 will decrease as a result of increased ventilation and removal of carbon dioxide. From the Henderson-Hasselbalch equation, we expect that the pH will increase in this situation. In this case, our kidneys will respond by trying to bring the pH down by excreting bicarbonate in the urine, and the expected change in bicarbonate will be as follows. For every 10 decrease in 10 millimeters of mercury of our PCO2, we expect in the acute setting that the bicarbonate levels will decrease by 2, and in the chronic setting our bicarbonate levels will decrease by 5. Looking back at our Henderson-Hasselbalch equation, after a decrease in PCO2 from 40 to 20, for example, our increase in pH will be from 7.4 to 7.7, with the expected bicarb change from 24 to 12 in order to get the pH back to 7.4. Again, this calculation is just for illustrative purposes, since there are other physiological effects that occur that helps prevent such a rise in pH, including attempting to slow down our respiratory rate. Similar to the expected correction for respiratory acidosis, the bicarbonate correction for respiratory alkalosis is about 2 to 5 for every 10 change in PCO2, as was shown in the previous slide. Now let's explore the pulmonary compensation mechanisms for metabolic processes. Pulmonary processes are relatively quick to respond in the order of minutes to hours, so you will generally see changes in the PCO2 after any effect to bicarbonate levels. When it comes to metabolic processes, metabolic acidosis is the most commonly observed disturbance and is usually the effect of an increase in acid generation or addition of acid to the body system, or a decrease in acid excretion or loss of bicarbonate. These help us to differentiate what is known as a high anion gap acidosis, or gap acidosis for short, versus a non-anion gap acidosis. We will explore this more in depth in the coming slides. Let's see how this works through the Henderson-Hasselbalch equation. In our first step, our bicarbonate levels are decreased, for example from 24 to 12 in the setting of a metabolic acidosis. As you can see, the Henderson-Hasselbalch equation response is for the pH to decrease from 7.4 to 7.1. Our lungs try to bring the pH back up by increasing our ventilation. That results in a drop in our PCO2. We use this formula here, called the Winter's formula, which is the expected PCO2 is equal to 1.5 times the bicarbonate plus 8 plus or minus 2 to help predict the expected PCO2 for the bicarbonate level that we see. There are other shortcuts that you can use to help estimate the predicted PCO2, but this is one of the more common ways to make a more accurate prediction of what the PCO2 should be for any level of bicarbonate in our body in the setting of a metabolic acidosis. Now let's talk about that anion gap that I mentioned before. The anion gap represents the anions of acids that are added to the system that are not able to be measured through our normal laboratory values. Since the proton can be eliminated easily through bicarbonate buffering, what we are left with is sodium cations pairing with the leftover anions. This is nicely illustrated in this figure here. When we increase the acid level in the serum, we decrease the bicarbonate levels through proton buffering, but the anions are still left over. We calculate the anion gap as a serum sodium minus the anions of the chloride and bicarbonate, which represent the A and the SA portions of the figure here. We have a normal anion gap of around 12, but if we add or accumulate particular acids, then you can see we increase this anion gap substantially, as is shown here on the right side of this figure. Anything above 12 constitutes a high anion gap in these cases. As an aside, you also may see alternative formulas for the anion gap that include the potassium. Since the potassium concentration in the serum is small and almost negligible, we usually drop this term in the anion gap formulation that we use here in the United States. The potassium added formula is used in other countries, but also remember that your normal anion gap will be around 8 due to the addition of this potassium in this equation. For exam and practice purposes here in the United States, we would recommend that you use the equation without potassium. There are many causes of high anion gap acidosis, and you will see these through your time as a student, resident, and even beyond, especially on the inpatient setting. There are two main mnemonics to remember the differential diagnosis of high anion gap acidosis, or gap acidosis for short. These are mud piles and gold mark. But remember that lactic acidosis, specifically L-lactate, and ketoacidosis will be your two most common causes of a gap acidosis to remember. When it comes to non-anion gap acidosis, this is usually due to a decrease in acid excretion or a loss of bicarbonate. There are two main causes, either GI losses of bicarbonate or renal issues leading to an acidosis. We can differentiate between renal and GI causes by looking at the equation known as the urinary anion gap, with the formula urine sodium plus urine potassium minus urine chloride. If the result of this equation is positive, then you are looking at a renal issue, but if the result of the equation is negative, then you are likely looking at a GI issue. We use the urinary anion gap to represent how much ammonium is being excreted. Unfortunately, we aren't able to easily measure ammonium, so we use the urinary anion gap to help us get an estimate of this value. Ammonium is a positive cation, so it will go on the left side of this figure here. You can see that if we have a lot of ammonium, as is seen here, the urinary anion gap will likely be negative. However, if we don't have enough ammonium, or if we aren't producing enough ammonium, then the urinary anion gap formula will produce a positive result. Now let's delve into how this actually works. When we have GI bicarbonate losses, such as with diarrhea, the excess protons that are retained in the body have to be eliminated by the kidney. Recall from our previous videos that once we excrete these protons into the urinary space, we use ammonia to absorb all the excess protons and convert it into ammonium. Since we'll have a higher amount of ammonium as a result of this process, this will ultimately lead to a negative anion gap. What about renal losses leading to that positive anion gap? This is where it actually gets interesting. In the setting of a type 1 or distal RTA, recall that proton secretion is impaired, hence the amount of ammonium that is produced is lower, and we will usually get a positive urinary anion gap. Similarly, with a type 4 RTA that results from an issue with ammoniogenesis, since we aren't producing ammonia, the amount of ammonium being produced will be lower, and hence the urinary anion gap will be positive. Now, what about that type 2 or proximal RTA? Well, in this situation, bicarbonate reabsorption is usually the main issue, but ammoniogenesis and proton excretion are not impaired, hence the urinary anion gap is variable depending upon how much bicarbonate is excreted versus ammonium. But usually the anion gap in this situation is negative due to more ammonium being excreted compared to bicarbonate due to the distal tubule's ability to reabsorb some of the excess bicarbonate anions. Now that I've presented the anion gaps, I wanted to make sure that you guys are aware that there's two different anion gaps that we usually talk about. So one of them is the serum anion gap, which is the sodium minus chloride minus bicarbonate. And we use the serum anion gap to differentiate between non-anion gap metabolic acidosis versus a high anion gap metabolic acidosis. Now the urinary anion gap is calculated as the urine sodium plus urine potassium minus chloride, and this is to differentiate GI versus renal causes when we have already established a non-anion gap metabolic acidosis. Please review this concept very carefully because there's a lot of different questions and sometimes different gaps can be very confusing to look at. Now let's talk about metabolic alkalosis. This usually happens in the setting of chronic volume contraction, such as with GI losses, but it can also happen with diuretics and genetic conditions such as Bartter-Gittleman or Little syndrome that make the kidney look like it's under the influence of a diuretic. There's also a rare condition called milk alkali syndrome that metabolic alkalosis can occur as well through high ingestion of alkali as well as milk products. In metabolic alkalosis, our primary disturbance is the bicarbonate levels will start to increase. Subsequently, as you know with the Henderson-Hasselbalch equation, the pH level will rise accordingly, and the lungs will try to decrease that pH back to normal by decreasing ventilation, and our PCO2 generally will increase, and this is called respiratory compensation. Our expected PCO2 will be this equation here, 0.7 times the bicarbonate plus 20 plus or minus 5. So this is a little bit similar to the Winter's formula in calculating the respiratory compensation for metabolic acidosis, but the numbers here are a little bit different for calculation of metabolic alkalosis. So let's take a closer look at that. So with regards to a metabolic alkalosis, we, for example, increase our bicarbonate from 24 to 36. Through the Henderson-Hasselbalch equation, our pH level will rise from 7.4 to 7.9. And in the third step with pulmonary compensation, our increase in PCO2 will be done to decrease the pH towards the normal levels of 7.4 with this equation that we have here. Now remember, these are just numbers that I have put into the calculation, but don't necessarily reflect the actual physiologic changes that we see in patients. Now let's talk about what happens when we have multiple processes going on. In this case, our actual bicarbonate or PCO2 may not be what is expected, and this will signify to us that there are other processes going on that we must consider. It is common to get combination of 2 to 3 different acid-base disturbances, as shown here, and going through the process of interpreting blood gases stepwise will help to ensure that you don't miss any of these other acid-base disturbances. I also wanted to introduce another equation to you called the delta gap, which is when you already have an established presence of a high anion gap metabolic acidosis. This will help us to determine if there's something in addition to the process leading to the gap acidosis that is going on. The equation is the difference between the anion gap and the normal gap of 12 divided by the difference between the measured serum bicarbonate and normal serum bicarbonate level of 24. Usually, the offset between anion gap and bicarbonate is in a 1-to-1 ratio, meaning that the delta gap calculation should usually yield a ratio close to 1. If our bicarbonate is lower than expected, then this will widen the denominator spread and decrease the delta gap, leading to a ratio less than 0.8. In this case, we can say that there is an additional non-gap acidosis that is causing the drop in bicarbonate lower than expected. Conversely, if there's something that's driving the bicarbonate higher than expected, the denominator difference will narrow, leading to a higher delta gap result. Remember that there are actually two things that result in a high bicarbonate value, either a metabolic alkalosis or a respiratory acidosis. Sometimes you will be able to tell the difference if you already have an ongoing respiratory process. Because you can only have one respiratory process at a time, but multiple metabolic processes, this rule can help you differentiate between the two processes. Now let's use what we learned so far and put it to use with interpreting arterial blood gases. Let's first review what information we can glean off an arterial blood gas. First, we can assess the oxygenation of a patient with both the partial pressure of oxygen, PaO2, and the oxygen saturation. Second, ventilation can be assessed with the PaCO2 or PCO2, partial pressure of carbon dioxide, which essentially tells us how well the lungs are able to excrete acid from the body. Third, the bicarbonate levels in the blood help us to ascertain how well our kidneys are able to get rid of excess acid from our body and how well the kidneys are able to retain bicarbonate. The pH of the serum then serves to represent the balance between acid generation, acid excretion, bicarbonate retention, or excretion between the lungs and the kidneys. While there are several methods to interpreting ABGs or arterial blood gases, this is the method that I found works for me in a stepwise process. It doesn't matter which method you choose, so long as you remain systematic, since some of the more complicated cases don't become apparent until after you get to step 5. In step 1, we first determine whether you're dealing with an acidosis or an alkalosis by looking at the pH. In step 2, we determine if it's a primary metabolic or respiratory issue going on. In step 3, we calculate the expected metabolic or respiratory compensation for the primary acid-base disturbance, and if it's off, then we can identify other acid-base disorders. In step 4, we calculate the serum anion gap. Remember the formula being sodium, the serum sodium, minus the chloride, minus bicarbonate. And in step 5, if we have identified a high anion gap metabolic acidosis from step 4, then we can calculate the delta gap to see if there's any additional acid-base disturbances ongoing. This will be a review again of what the expected numbers are. If we are at a pH less than 7.4, In the acidotic range, we then look at the PCO2 and bicarbonate. If the PCO2 is greater than 40, we're usually dealing with a primary respiratory acidosis. And if the bicarbonate is less than 24, then we're usually dealing with a primary metabolic acidosis. If they are both moving in the acidotic environment, then you will likely have a double acid-base disturbances of both a primary metabolic and primary respiratory acidosis. Conversely, if you have a pH of greater than 7.4, we then look again at the PCO2 and the bicarbonate levels. If the PCO2 is less than 40, this is indicative of a primary respiratory alkalosis, whereas a bicarbonate level of greater than 24 would be indicative of a primary metabolic alkalosis. If these numbers don't quite fit, you likely have many multiple processes, and you just have to analyze one process at a time to establish what the other processes are. These are the formulas again for expected compensation. You'll want to save this slide for a future reference, but you can easily look up this information online in case you lose it. Remember that after you calculate the expected metabolic or respiratory compensation, if you have actual measured values above or below what is expected, then you have another primary acid-base disturbance going on. After calculating the serum anion gap, we calculate the delta gap, which is represented by the formula here. Recall that in a pure high anion gap metabolic acidosis, we expect that the change in bicarbonate should be essentially account for the change in the anion gap. So the delta gap value should be around 1. If the ratio is less than 1, the bicarbonate level is lower than expected for the anion gap, which signifies that there's something else driving the bicarb lower, and we likely have a concomitant non-anion gap metabolic acidosis. Conversely, if the ratio is elevated greater than 1.8, then the bicarbonate level is higher than expected for the anion gap, and we have something driving the bicarbonate level higher than expected, which can signify either a metabolic alkalosis or a respiratory acidosis. Remember that only one respiratory process is allowed. Let's talk very briefly about the bicarbonate fallacy. Many times we will look at the chemistry panel without an ABG and declare that the low bicarbonate level is due to a metabolic acidosis. In the majority of the time, this is true, but as you can see here in this ABG example with a pH of 7.7, PCO2 of 24, and a bicarb of 19, a low bicarbonate here is actually compensation for a respiratory alkalosis. If we use our compensation formulas, we expect that the drop in bicarbonate from 40 to 24 will drop the bicarbonate level. We expect a drop in the PCO2 from 40 to 24 will drop the bicarbonate level about 3 to 4 points in the acute setting. Remember that expected compensation is expected bicarbonate compensation is about 2 points for every 10-point drop in the PCO2 level. Hence, the bicarbonate level of 19 is actually a compensated respiratory alkalosis without an underlying metabolic process. The kidneys are doing their job responding appropriately to the high pH by trying to get rid of bicarbonate, resulting in lower bicarbonate levels. So this is metabolic compensation for the respiratory alkalosis. Conversely, a high bicarbonate level, again, is not always a metabolic alkalosis, and you'll want to rule this out by getting an ABG and making sure you don't have a respiratory acidosis. Now you have learned all the ins and outs of the theory behind blood gases and how our lungs and kidneys work in sync to bring homeostasis in our acid-base environment. Practically, we use ABGs all the time to determine what is going on with our patients, sometimes multiple times a day, especially in the ICUs. In the next video, you'll have a chance to try using what you have learned in this video and see if you can crack some actual ABGs. The more you practice, the more you'll become familiar with ABG interpretation. That's all I have for you today, and thanks for listening today on this talk on acid-base disorders. Please feel free to join me in my other videos on YouTube where I explore all the aspects of the kidney.